in the series of 6. My name is Tamara Henry Paris, and I am with the Central East ATTC. Our project director, Ryan Springer, he's actually away at a meeting in California, and he sends his regards. For those of you who are new to the call, we are one of 14 ATTCs and a national office within the United States. In addition to our 6 series webinars that we're holding, we're also will be having a national TOT, a training of trainers on for clinical supervision on July 16th through the 19th with Dr. Steve Gallen and Kate Speck. If you are interested in participating in that, we'll also send out information regarding the TOT. I want to let you know, in order to participate in this TOT, you will have had to complete the Foundations course successfully. The following regional centers have conducted and completed their foundation courses. So to give you some housekeeping rules for today's webinar, each of you all should have a panel in your right-hand corner. In order so that panel won't be blocking the PowerPoint slide, you can press the orange button, and that orange button will minimize your slide. So it will look like that smaller toolbar on the corner. All the lines for this call have been muted, so in order to participate in the question and answer feature, there will be in that same dialog box, there is a message box where you can submit your questions there. So that everyone also knows that you will receive 1.5 NADAC and 1.5 NBCC CUs for attending the entire website. Participants will receive their certificate of attendance within 10 business days. As I've mentioned before, this is the 3rd webinar in the series. We have all the webinars, the previous webinars are posted to the ATTC site as well as the Danya Institute site. And again, information will be sent to you where you can locate those slides. So I'd like to take the time out now to introduce our facilitator, Dr. Stephen Gallen. He's an adjunct professor with the Department of Health and Preventative Medicine at Oregon Health and Science University. Dr. Gallen is the former director of the Northeast ATTC. He is also a process improvement coach with NIATEX. Dr. Gallen is a skilled trainer in various topics, clinical supervision being one of them. And now, without further ado, I would like to change it over to our presenter for today, Dr. Stephen Gallen.
Thank you, Tamara. Hello, everybody, again. Glad to be back. This is, as Tamara said, this is the 3rd in our series of clinical supervision webinars that we're doing. I'd like to start off by thanking the Central East ATTC for hosting this event and for the National ATTC office for assisting us with the technical aspects of the program and also recording and posting the program on the website. This has been an interesting series. We have had a very good response so far, so I'm looking forward to talking with you today as we move forward. Interestingly enough, I'm having trouble advancing my slides, so bear with me for a second. There we go. As Tamara mentioned, this is the 3rd of 6 presentations. The first 2, the first program focused on the clinical supervisory interview, and we focused really on doing corrective interviewing and how to provide performance feedback. The second webinar focused on the liability issues we face as supervisors, liabilities for the work of our counselors, and talked about some of the issues involved in how to minimize that liability. Today's focus is going to be on boundary issues in supervision. And then in the subsequent programs, we're going to take a look next time at keys to performance success. How do we go about assuring that our supervisees are growing and improving in their service delivery? And then the August program will focus on how we can use data in supervision to provide performance-based feedback to our supervisees. The last session will focus on a project that the Network for the Improvement of Addiction Treatment and the ATTC network are working on together. And that should be an interesting program. So today's focus is on boundary issues. As supervisors, we all have responsibility for evaluating job performance. It's a role that includes unusual and extraordinary power and influence over others, and as a result of that, carries with it some potential for abuse. Today we're really going to be trying to raise our awareness of how we can use our power as supervisors effectively and at the same time protect the rights of our supervisees and the rights of our clients. We're going to be focusing on two major issues. The work we do with our supervisees in helping them improve the quality of relationships they have with their clients, and how boundary issues can sometimes either facilitate or impair the development of that relationship. And then we're also going to take a look at our own relationship with supervisees and how we use our power and our influence to help supervisees achieve as much as they can in their role with the agency. In the counseling aspect, we're going to talk about numerous boundary issues related to not only personal relationships but also business relationships, physical contact, closeness, the degree to which we sometimes can avoid encountering people outside the counseling setting, and also record keeping, taking a look at some of the issues that relate to boundaries and the information we write down. With supervisees, we're going to also look at potential areas of conflict of interest, our own outside relationships with supervisees. Many of us have been promoted from a counselor position or some other position in the agency to the supervisor role, and the relationships we have with our former peers gets adjusted as we adopt that supervisor role. So we're going to talk some about the issues around those boundaries. You may ask, well, what kind of problems do we have related to boundaries? Well, the source of, we're going to talk a lot about those today, but the source of those issues really can be, I think, boiled down to two issues. One is that clinical supervision in recent, I would say in the recent past, in the last 10 to 15 years, has played a decreasing role at our agencies. And because clinical supervision has been de-emphasized, that brings up the potential for some boundary violations because we just don't have as much close contact with our supervisees. It's a national problem that SAMHSA is beginning to address, and individual states are also addressing. So you're probably seeing more information on the web, more information coming out from places like the Addiction Technology Transfer Centers about courses in clinical supervision and standards for clinical supervision. New publications have been released in the last few years around things like competencies, clinical supervision competencies, and the like. So let's get started. Again, I'm having difficulty advancing slides, so bear with me as I try to resolve that technical problem. Here we go. Let's ask ourselves, what's a boundary? Well, the definition we can use is that it's a line. It's sometimes a line that's very difficult to define, that separates acceptable from unacceptable behavior. It has to do with how we interact with others, how our counselors interact with their clients, and how we interact with our supervisees. Often the issues that still having trouble advancing slides. Bear with me while I try to solve this technical problem. The boundary issues are often influenced by a number of variables. One has to do with the scope of practice of the individual. If we're talking about counselors and therapists, or we're talking about case managers, or we're talking about people who might be peer recovery specialists, the scope of practice is going to define the degree to which boundary issues may interfere, and what the actual boundaries are. What constitutes a boundary crossing will vary depending on the scope of practice in the job. The personal competence of the individual, the cultural competence, the degree to which the worker understands the client and what the client's limitations are, will affect whether or not the counselor is sensitive to the boundaries and boundary issues in the relationship with clients. What's the context or the situation? We're going to talk about how in recent years with new therapies, more and more our work goes out into the community and we're encountering clients in the community. So how does that context affect the traditional rules around boundaries? And then lastly, what about our codes of ethics, and what's the degree to which our codes of ethics provide us with some insights into boundary maintenance and provide us with some guidelines and suggestions. Now, because boundaries are difficult to identify and to define, I was reminded of a quote that's been attributed to St. Augustine, and it reads like this: "Time, I know what time is," says St. Augustine, "provided that you do not ask me." In other words, we have a sense of what boundaries are, but if we're uncertain about the definition, then it's going to be very difficult for us to articulate. So my hope is that we're going to shed some light today on this issue. Before we get started, I want to acknowledge the work of Ken Pope. Kenneth Pope, if you're not familiar, I've included his website address here. He has spent the last 20 years, he's a psychologist, board certified by the American Board of Professional Psychology, a highly regarded psychologist who has spent the last 20 years developing free resources on the web for us to use, people who are in the delivery, in the process of delivering services to people with co-occurring disorders, substance use disorders, psychological disorders. He has a section on his website that's focused on boundary issues, and that's what I want to encourage you to look at. On his home page, you'll notice a menu, a drop-down menu on the left-hand side, and boundaries are one of the topics that he covers. And he has a great number of articles that provide us with some real food for thought with regard to boundary issues. And he has two seminal articles which are really classics in the field, and I love to refer people to some of these classical articles in the field because they're really the source for a lot of the thinking and the discussion that's gone on in the last 20 years about boundaries. And those authors are Thomas Guthiel, if I'm pronouncing that correctly, and Glenn Gabbard. And I won't read the titles of the articles here, they're listed here, but you can download them from Ken Pope's website. And I really encourage you to take a closer look, because in the time we have today, we won't be able to examine all the issues as closely as we might. But these articles and others that Ken Pope and his colleagues have written, which are all posted on the website, can really be helpful to us as we think through how to facilitate our counselors and supervisees really managing boundaries well, and how we can manage boundaries with our supervisees more effectively. So let's talk about let me share with you. Well, before I talk about boundary crossing, I told you I wanted to illuminate or shed some light on this topic. On Ken Pope's website, he has a little bio sketch of himself, and I'm going to read you the last paragraph of the bio sketch because it shows his humility, but it also is an example of what we're going to be trying to do today, shedding some light on a topic that may have some dark corners for some of us. He was an undergraduate at Harvard, and midway through his studies, he was a literature major. He decided, after being inspired by Dr. Martin Luther King and others, to really change his vocational objective. And he began to take courses at Harvard in a broad variety of topic areas. And he went to an advanced course in the medical school as an undergraduate. And he says this about that course. He says, the first day I was already lost. The professor kept asking if we saw various structures in our microscopes. Everyone nodded yes, but I had no idea what he was talking about. And I was too embarrassed to admit I couldn't see any of the structures that he was describing. Finally, I raised my hand and confessed to the group. He looked at me for a long time, then came down the aisle, put his hand on my back, leaned down to the floor, and plugged in my electronic microscope. Sometimes he says that's all it takes to shed some light on a subject. So my hope is that we are going to shed some light on this issue of boundary issues. Here's my orientation. We most often in the literature and in our own settings are most concerned with boundary violations. But let me broaden the topic a bit and suggest to you that not all boundary crossings should be considered violations. Boundary crossings can be salutary. They can be beneficial and helpful to the client. They can also be neutral. You know, a boundary crossing may, in a very traditional sense, be when I encounter one of my clients on the street in the community. And depending on how I handle that meeting, it can have a neutral effect. It could also have a salutary effect, but it could also have a harmful effect. Harmful effects are really what we're talking about when we talk about boundary violations. Things that we do or things that our counselors do that have a harmful effect on either our supervisees or our clients. Those are the things we want to avoid. But we don't want to throw the baby out with the bathwater. We don't want to consider that all boundary crossings are bad. Boundaries can be sharp, can be crisp, can be very clear what's allowed. Sexual contact between a counselor and a client, of course, that's a crisp definition of a boundary violation that should not occur. But other boundary issues can be flexible. Things like attending a 12-step meeting or being on a community committee or somehow having an unexpected encounter at a social gathering with a client. And that kind of a boundary crossing depends on how we handle it as to what its impact might be. So there are a broad variety of boundary crossings. In fact, we're going to take a look at 10 different ones during this webinar. However, there's a caveat that I need to share with you. Legally, if you ended up in court as a result of some action that either a counselor of yours took or that you took yourself, something happened that someone took exception to. In the courts, there tends to be a kind of literal, black and white, mechanical interpretation of boundary crossings. And in legal settings, often when a boundary crossing has occurred and it's been verified, it gets interpreted as a violation or a negative or a harmful event. So with that as a context, we really need to be careful. And so my hope is that today we'll take a look at some guidelines that will help you be careful in deciding to cross what typically have been defined as cultural barriers or boundary barriers. So when we think about a crossing versus a violation, how do we go about making that determination? What constitutes a crossing? Well, it's easy when we think about such sexual contact. But how does sexual contact evolve? Sometimes as supervisors or as counselors or as colleagues of a counselor, we see some things happening in the clinic that give us pause, that create questions in our minds, but we don't take action because they seem so minor. But what we need to realize is that when a sexual encounter occurs between a client and a counselor, for example, or a caregiver, often it's the result of a crescendo of events that start off innocent and or mildly innocent, and then gradually moves to more and more inappropriate behavior on the part of either the client or the counselor. So recognizing that even the most harmful of violations doesn't happen overnight, but happens sequentially and over time. And we need to be willing to raise issues early before something becomes a problem later on. Often there are clues that we just don't pay attention to, that we don't feel comfortable raising, and I'm going to be encouraging you to raise those issues. Second principle in making a determination about whether or not something's a violation or just a crossing has to do with context. Everything has to do with context. The counselor's expectations, the client's expectations, the agency's expectations, the client's background, the client's limitations, all of those constitute the context. And if we don't have an understanding of that context, it's very difficult to make a determination about whether something's just a crossing, has a neutral or even a salutary effect, or whether it has a harmful effect. Context is everything. And lastly, the last principle is that because boundary crossings often get interpreted in a more mechanical or black and white or judgmental fashion, it's really going to be important for us as supervisors to encourage and to do some instruction and to provide some continuing education for our supervisees around what constitutes boundary crossings and boundary violations, and really encouraging people to avoid even the appearance of boundary violations. And coming up with some scenarios that might happen in the future in the clinic, and how would we handle those, and literally developing a plan for how to manage difficult situations. So, in reconsidering the definition then, let's take a look at what we've talked about so far. We've talked about the fact that a line distinguishing professional from personal is difficult to pinpoint with regard to relationships. That a broader definition of boundaries might help us in considering the benefits and the risks of crossing what might be termed a traditional boundary. Considering the context and the situation, the specific facts of a situation, will help build an understanding of a situation and whether or not it constitutes a risk for the agency or a risk for the counselor or a risk for the client. And finally, when a violation when a harm has taken place, when somebody has taken exception to or feels harmed by the behavior of a staff member, that, from the client's perspective, constitutes a violation. And we need to understand the context within which the decisions got made if we are to understand the nature of the violation and to prevent it in the future. So I mentioned we're going to talk about a number of issues. This classic article that I mentioned earlier that's posted on Ken Pope's website by Guthiel and Gabbard, they talk about 10 issues, boundary issues, and we're going to touch briefly on each of them. Role, time boundaries, place and space, monetary boundaries, the role of gifts, ancillary services, clothing and the way we dress and the communication that happens around the nonverbal ways we present ourselves. Language, the verbal aspects of boundaries. self-disclosure and how that affects our clients as a boundary issue. And finally, physical contact, the more obvious boundary violation or boundary crossing that takes place. So we're going to take a look at each of these individually during the next hour. Let's start with role boundaries. This is the issue. The question is, what is the counselor's or the supervisor's role? What's the job description? What kind of activities are we asking the worker to engage in with clients? All of that will help us determine where the boundaries are and what lines should not be crossed with regard to behavior. What do patients and supervisees, having trouble managing my screen here to see, what do patients and supervisees often want? This is a critical issue. So often, both patients and supervisees are looking for something that I would call, and Hope calls, the ideal parent. They're looking to be, they want to be understood. They want their needs to be gratified and taken care of. Very important issues, and not always easy for us to define. And certainly counselors are not able to meet all the needs of supervisees. If you notice a little frustration in my voice, it's because I'm having trouble getting these slides to advance. Hold on just a second. Here we go. We have to ask ourselves as caregivers, are the wishes of our clients and the wishes of our supervisees legitimate? And of course they're legitimate. The question is not really how legitimate they are, but how far do we go in meeting those needs? How strictly should boundaries be enforced? In clinical settings where you are dealing with, our counselors are dealing with clients, I think the boundaries are much more easily defined depending on the role the counselor is playing and depending on the kinds of clients they're working with. And we need to be instructive with them about what those boundaries are. With our supervisees, the boundaries can be a little more flexible. We'll talk about the flexibility of those boundaries as we proceed here. Should boundaries be determined on a case-by-case basis? My answer to that is yes, because remember, context is everything. Boundaries for one client, a sensitive boundary for one client may not be a sensitive boundary for another client. Something that may be helpful to one client may not be helpful, may be harmful to another client. So we need to attend to the context and our understanding of the limitations that our clients have, as well as the role that the counselor is playing in the agency, or the case manager, or the peer recovery specialist. So role is one type of boundary, but what about time? What I'm thinking of here is that there are time limits for our sessions. Usually counselors have a limited amount of time. A group session is 90 minutes or 120 minutes or 2.5 hours or however long it might be. A counseling session may be 50 minutes, it may be 20 minutes, it may be a maximum of an hour and a half if we're doing an assessment. What happens when those time boundaries get violated, where those time boundaries are crossed? Could that be an indicator that a relationship, a complication in the relationship between the counselor and the client might be taking place, something to be talked about in supervision? How frequently do clients come in to see the counselor? Often depends on the individualized treatment plan. Something for us to monitor, very frequent contacts or contacts that go beyond the time limitations, the traditional time limitations in the agency, might be something to talk about. What about telephone calls? What are the limits around telephone calls? And how frequently do clients have an opportunity to call the counselor, or the counselor call the client? And how are we as supervisors able to monitor the frequency of those calls and when they actually happen? How many of us actually know about the frequency of contact that our counselors are having with their clients over the telephone? All of the answers to those questions depend on the nature of the agreement that has been struck with the client around the services that are going to be delivered and the treatment goals that have been established. So time boundaries. A third type of boundary, place and space. If contact with the client typically happens in one location, in the clinic, in the group room, in a counseling office, in another office in the community, in a medical setting, or a home visit, if contacts begin to get scheduled outside the usual setting, whatever that usual setting might be, that may be an indicator to us that a relationship that includes a boundary crossing is evolving. So how do we monitor as supervisors where those client contacts are occurring and how often they're occurring? Are they being constructive, or are they somehow intrusive? And sometimes clients will be very hesitant to complain if they feel like their privacy is being invaded, or they're being asked to do something that they don't embrace totally. So we as supervisors need to raise these issues with our supervisees, with our counselors, and raise questions about the intrusive nature of the form of care that's being delivered. When we go out into the community and meet with clients, an issue that an agency always has to ask themselves is, do we condone situations in which a counselor of one gender meets with a client of another gender? And do we have a policy about somebody of the complementary gender accompanying the counselor to or the case manager or the peer recovery specialist when they're encountering a client? Something to think about. There's cases to be made for making sure that teams of two go out in the community when you're meeting with clients in the community, and the case can be made for that's kind of overstepping and maybe a boundary violation itself. So that's something to think about. Remember that innocent contact in the community, helping a client meet a treatment goal, can lead to a crescendo of events that result in a harmful boundary crossing, a violation. When we decide to cross a boundary, when we meet with a client in an untraditional setting, that's when it's really important, I think, to document the rationale and the benefit that we expect the client to accrue, and put it in the clinical record. To document that rationale and what happened as a result. What are the facts of the contact, and keeping a record of that in the clinical record. Very important, just in case something happens later and there's a complaint being issued by a family member or by a client themselves. Monetary issues. When we provide supervision, typically if we don't work in an agency but we're contracted, we expect to be compensated. When we deliver treatment services, in most settings, we expect there to be a compensation. So the question rises around monetary boundaries is what happens when we go against the traditional grain with regard to compensation. For example, what if I were to provide services where we usually charge a fee, even a scale-adjusted diminished fee? Should we actually provide services at no charge to some clients? And does that constitute a boundary violation or a boundary crossing that would result in more obligation on the part of the client? Would the client feel some guilt, some hesitation, some additional obligation to the agency, some need to perhaps repay the agency? All of those complications have to do with boundaries. And another related issue is what happens to situations in which a client may not pay or a patient may not pay their bill and accrues an account that's receivable. How does that affect the counseling relationship? How does that affect the relationship with the agency? Could it compromise the quality of care being delivered to the client? A boundary issue. We often don't think about monetary boundaries, but they can have a significant impact on the quality of the relationship. In a private practice setting or even an agency setting, what about bartering? Sometimes deals are struck where services are delivered in exchange for not money but goods. There's risk involved in bartering, although bartering is not really a violation of any code of ethics. Bartering is allowed, but it does carry some risks. What happens if the person delivering the service receives compensation from the client but doesn't think that the compensation from the client is of sufficient value? Or vice versa. What if the client feels like they haven't gotten a fair deal, they've given more in terms of goods than they've received in terms of quality of care? So lots of potential for risk there if we engage in bartering. Best way to avoid conflicts, I think, is to be very clear about the monetary nature or the fiscal nature of the relationship and how fees are to be gathered, collected, how they're assessed, whether or not a bartering exchange is going to be allowed, what are the rules around that, what are the limitations around that. Really informed consent is what we're talking about here, and making sure that the conditions under which we're providing services are very clear with regard to fees. Okay, fifth issue is around gifts. Many of us grow up learning from our academic training or from our supervision that gifts are not allowed. And yet if we take a black and white view of gifts, in fact we could be causing harm. Gifts to clients or supervisees, I think that's fairly clearly a boundary crossing that we should avoid. We, counselors, are in a position of power. The agency is in a position of power. We as supervisors certainly are in a position of power. Giving gifts to our supervisees creates a sense of obligation, creates a quality of reaction or response that we just can't be totally aware of. But what about gifts from clients or supervisees? In some cultures, it's expected that a small, modest gift might be given at a certain time, maybe at a graduation or at the conclusion of care or around a special holiday. And if those gifts are very modest, do we run the risk of alienating the client, of really committing a cultural error if we don't accept those gifts? So what are our rules around gift receiving? And can we have rules that take into account the context? What about the interface between our methods and manners? That has to do with the issue I was just talking about. Is it good manners to accept a gift and be appreciative of something small, a calendar, a flower, a plate of cookies, whatever it might be? Or if we're totally focused on the method, on the black and white interpretation of the rules, do we run the risk of potentially alienating others? So the question of what is appropriate really comes down to a case-by-case basis. An exception might be educational gifts that are used in treatment. We give books, or we give tapes, or we give some kind of tools that clients can use to further their recovery. Could those be exceptions to the rule? Could we allow those gifts? I would say yes, especially if it's couched in terms of this is part of care. This is a standard operating procedure with the agency that we make available these tools to our clients, and we're being compensated by the fees that the insurance company or that the state or that the client is paying. So educational gifts used in treatment might be an exception to this traditional don't give gifts to clients or supervisees. So in review, we've covered half of these boundary issues now. We talked about role, the boundaries around time, boundaries around place and where we meet clients, boundaries around how we handle money, and boundaries around gifts. So let's now turn to these other 5 areas: services, nonverbal statements with regard to how we dress, language we use, self-disclosure, information, personal information that we might share, and of course physical contact. Let's take a look at those issues next. Service boundaries. Now all of these 10 topics, by the way, are issues that you can raise as supervisors as an in-service training, as a discussion that can be raised with your supervisees to raise their awareness that boundaries just aren't physical contact, just aren't sexual, but really there is a complexity of boundaries that we're talking about. Service boundaries. Counselors conducting business with their clients. Sometimes this happens outside of our awareness, but what about a counselor who has a client who's in business for himself or herself and hires the counselor or hires the client to mow a lawn or to provide a service to the family or provides a cord of firewood? What about think about that as a potential boundary violation or a conflict of interest. And in the same regard, what about supervisors who do business with supervisees? What if a supervisee provides me a service for which I compensate the supervisee? Here are the issues. There's an impact on the relationship with the client or with the supervisee. With clients, it may be that they feel like they're now occupying a special place in the mind or in the heart of the counselor, that they've managed to develop a special relationship that isn't shared by other clients. Or what about the supervisee and the supervisor getting together for social events outside the context of work? Sometimes in small agencies and small communities, or in situations where the supervisor has been promoted and is close friends with former peers, very difficult situations to manage and very difficult to give black and white suggestions with regard to what's most appropriate, but very important to make a topic of conversation and supervision. And what about the impact on others who don't have the special relationship? What happens when clients discover that a counselor has hired a client to provide a service? Or what happens with the rest of the staff members when the staff members know that a supervisee is delivering a certain service to a supervisor? What about the impact? Things to think about. Again, difficult to draw clear definitions about what's appropriate. It's all context. Now, clothing boundaries. Clothing boundaries, these are social boundaries within the culture that we operate. The different cultures, different clothing expectations. But certainly revealing or seductive clothing is a violation, and it's really a violation in two directions. It can be a counselor dressing inappropriately for providing clinical work, or it could be a supervisee coming in dressed very inappropriately, perhaps with the intention of being seductive to the counselor. So this bidirectional boundary crossing is something that really needs to be discussed in supervision. Certainly if I have a supervisee who is dressing inappropriately, I need to be willing to raise that topic. It's a sensitive topic, but I need to raise it and talk about it in the most objective terms that I can. In situations where supervisees are exposed to inappropriate behavior on the part of clients, that also needs to be talked about. It needs to be okay to talk about situations where counselors aren't certain how to handle, how to respond to clients, and certainly role-playing and practicing situations that can be potentially result in boundary crossing needs to be part of the agenda for your supervision. Language boundaries. Tone of voice, how critical we are, word choice, all of those issues. I'm thinking of times when I work with folks who are adolescent counselors, and the degree to which they engage in using language that's comfortable to adolescents. Would it be appropriate for them to use only the majority culture language in dealing with adolescents? Let's say one of the states in our region is Hawaii, and in Hawaii, young people talk very differently from older people. There's a kind of a pidgin Hawaiian English that gets used, and counselors who don't use that kind of language set themselves apart and may be viewed as ineffective by their audience. So certainly the tone of voice, word choice, very appropriate. Very, very important to talk about how we communicate with our clients and what our clients' expectations are. Language boundaries has to do with intent. Am I trying to make contact with the client? And do I violate a language, cultural barrier or boundary inadvertently by trying to use language that is most identifiable or appropriate with a certain clientele? A clear example, one that happened when I was a supervisor, supervising a woman who had worked in correctional settings and was working in an outpatient clinic, and greeted her correctional clients in the waiting room on this one particular day with some profanity and with some enthusiasm and with some loudness. She didn't think anything of it. It was part of the culture of the client. However, she wasn't aware that the county commissioner was sitting in the waiting room also waiting to talk to the clinic director, and the county commissioner took offense at the way the interaction came down. And guess who got called? I, as the supervisor. So it has to do with context again. You know, the language that the counselor uses in her office with the client may be one thing. The language that the counselor uses to greet the client in a public setting may be totally different, or might be, to make it most appropriate, might be different. So misinterpretation is a real risk. Self-disclosure. Disclosing personal information has risks. The question I ask is, whose needs are getting met? Do I have a personal need as a counselor to disclose about my use history or my recovery history to the client? And whose needs am I meeting when I do that kind of self-disclosure? Is it helpful to the client? Or is it somehow perhaps inadvertently alienating to some others? How is self-disclosure in supervision different from self-disclosure in a clinical situation? I would say yes. Self-disclosure in supervision might be, in some settings, very appropriate to talk about how I dealt with situations that were difficult for me when I was working online as a counselor that I might want to disclose to a supervisee, whereas the same kind of disclosure to a client might be very inappropriate. So what's the impact on the client when doing self-disclosure? Lots of different viewpoints around self-disclosure. My preferred guideline is that if I'm disclosing in the moment feelings that I'm having or reactions that I'm having to the client can be very helpful and very appropriate. if I'm sharing stories or talking about difficulties I've had in my own life or talking about barriers that I had to overcome in my own recovery, that might not be as appropriate. Again, depends on context. Just know that the risks we run may be greater than they seem in terms of how others respond. If I acknowledge, for example, my drug of choice if I'm in recovery, and I have a mixed group of clients, how do I know that I'm not alienating some clients who have not used the particular drug that I use but choose something else? How do we know that they might not be saying to themselves, well, he won't understand me, he hasn't done what I've done? Disclosure sometimes carries risks that we don't see. Finally, physical contact boundaries. These are always subject to interpretation. But it's the interpretation of the client that's the most important. So how do I become aware of client expectations, of when I'm crossing a boundary, when I'm giving a message that I don't intend to give? How do clients interpret physical contact? What's the impact of the contact in terms of the future? Am I building expectations for more contact in the future if I have physical contact with the client? When it happens, if it happens and it's out of the ordinary, I'm not talking about regular day-to-day events, although I am reminded of the cartoon of the woman therapist who encounters her new male client, and the client sticks out his hand and she says, ha ha ha, I'm not falling for that trap. You know, I'm not talking about the extremes of a handshake, but when some physical contact happens that could be misinterpreted, really important for us to encourage our counselors to document that. What actually happened? Maybe the client reacts in a way that the counselor doesn't expect. Very important to document that. Maybe the next time the client comes in, they dress differently, or they talk differently, or they sit differently. Very important to document those kinds of things. The sequelae of physical contact sometimes doesn't play out immediately. And again, I come back to the question of whose need is getting met. Is it the counselor's need to have physical contact with the client, or is it the client's need? And what expectations are being established for the future? Physical contact, of course, is a source of significant risk, and we need to be careful about it, and it needs to be talked about in in-service training and during the regular course of our supervision activities. Okay, so conclusions. What conclusions can we come to as a result of talking about these 10 boundary areas that complicate our lives? Number one, boundary issues should be taken seriously, need to be a topic of conversation in supervision. Not all boundary crossings are inappropriate. Some can be very helpful. We need to help our counselors use their best clinical judgment. And if they plan a boundary crossing, perhaps encourage them to talk with us before they actually do it. Check it out with a trusted colleague, check it out with supervisor. Consider potential impact before taking action. How is the client likely to respond? And then finally, documenting the rationale, if we're planning, if an action is planned, and then what's the impact? What was the impact? Let's take a look at quiz number 1. I'm going to ask Olivia to open the poll. There are 3 questions in this first quiz, and Tamara is going to share the results. We're just going to give you about 30 seconds to respond to these questions. 30 seconds to respond to each one of the questions.
Steve, did you say that there were 3 questions?
Yes, there are.
It looks like we have 2 questions. I want to make sure we have the right quiz up. I do apologize.
Okay.
Carl
Manager is the first question.
Yes. Okay, so that is the first question. Okay, and we have the responses back. 87% said true, 13 said false.
Okay, well that's interesting in that my answer was false to that. Carl Menninger talked about when in doubt, go by the book. Actually, that's not a fair question because I rushed through that part of the presentation when I was having trouble advancing slides. And I didn't mention the Carl Menninger take. Carl Menninger's take, which I'll take advantage of the opportunity to do it now, his take is when in doubt, be human. When in doubt, if you're concerned about crossing a boundary, do what you think the most humane thing is, rather than going by the book. Because sometimes going by the book is sterile, keeps us from reaching out and expressing our empathy to clients. So, unfair question. My apologies for that one. Let's go to number 2.
We'll give a few more seconds and then we'll close the polls.
This one has to do with whether or not boundary crossings and boundary violations are essentially the same thing.
And 94% said false and 6% said true.
Great. Exactly right on the money. Boundary crossings can have a variety of impact, and boundary violations have harmful impact. Okay, the last question. In choosing to cross a boundary, we should consider the treatment goals of the patient and the cultural context from which the client comes, as well as agency policy and prevailing ethical standards.
All right, and we have the responses in for that. 100% said true.
All right, good. So we can see, thank you very much, Tamara. We can see that boundaries and boundary issues can be complicated and can have salutary, neutral, and negative effects. Now we're going to talk a little bit more. I'm going to ask you, those of you who might have questions, to begin typing them in. Tamara is going to review them, and at the end, when we have, hopefully we'll have a few minutes for question and answers, she'll screen your questions and ask those questions. But for now, we're going to, so I'm going to ask you to type in those questions into the chat box. We're going to go to boundary decisions. How do we go about making choices around boundary issues and around crossing boundaries? I'm not going to read these to you. I'm going to just post these on the screen. Look at these situations. Each of them involves a potential boundary issue. Our task is, how do we interpret these, and are there some guidelines we can use to help us answer some of these questions? One way of dealing with these issues is taking a look at ethical standards and using ethical standards as a guide. However, I would caution you that there are some precautions that I would suggest. One is that ethical standards and codes are really not a substitute for thinking. They're meant to be guidelines, but because when you've met one client, you've met one client, and the context is different from every single client to the next client, that the decisions we make need to be based on our understanding of the client as well as the ethical standards. So we need to continuously question, in my view, continuously question what's appropriate. What does this client need? How can we be most helpful? and recognize that the ethical codes are meant to be strictly guidelines. You know, what I notice is, for example, in the old days when we had 42 CFR, we still of course have 42 CFR. It's being changed now with modified to some extent with the changes in healthcare. But so many times we took a very black and white view of 42 CFR, when in fact we didn't look at the intent behind the confidentiality statutes. The confidentiality statutes were aimed to assure safety for people to come in and disclose a drug problem and get confidential treatment for that drug problem. But so often we refuse to share information with others that the client may have given us permission to do because we stuck too strictly to the guidelines. Current science can provide us with a variety of opinions, a variety of ideas, a variety of findings. And so I think we need to keep questioning. Always question research, material that gets shared with us, guidelines that we develop based on research. We should be constantly asking questions like, was the research done on our clientele in situations like the ones our clients face? Was that particular intervention or method tested with the age group that I'm working with or with the cultural group I'm working with? Always need to ask those kinds of questions. Another thing to realize is that we're not fallible. We're not infallible. We are fallible. We make mistakes. And mistakes need to be talked about and shouldn't be the source of punishment, but should be the source of education. So really encouraging people to talk about situations in which they felt confused or uncertain about how to handle a situation, or maybe they walked away feeling like they didn't handle it well. Making those topics okay topics of conversation. Question your own decisions and invite input. Ask a trusted colleague. Go to another supervisor. Ask them how they would handle a situation. Whether or not you handle a situation appropriately. Check it out and see what other people think. That consultation can be helpful and sometimes is crucially important to the future decisions we make, as well as to the debriefing and perhaps repair of any damage that might have been done by an error that we made. So ethical standards can be helpful, but they're not a substitute for our own ability to take a look at and discuss and take into account various contextual issues that may not have been considered in the development of those ethical standards. So when we decide to cross a boundary, are there some guidelines that we can use to help us make a decision? I'm going to share with you 9 quick guidelines for crossing a boundary. First, imagine what the outcome will be. What's the best outcome? What's the worst outcome? Is it worth the risk? If you're dealing with a borderline patient, physical contact with a borderline patient is always risky. What's the best outcome? What's the worst outcome? If the worst outcome is something you want to avoid, then my suggestion is the decision should be made not to cross that boundary. Consider what the professional literature has to say and what other colleagues say. Take into account in other words, take into account other opinions. Be aware, try to stay aware of ethical codes and guidelines and regulations and case law. They're changing. And in this time between now and 2014, 2015, I think you're going to see lots of changes in the way we practice. Be aware of those changes, about the regulations and the guidelines that people are providing, and ask questions. Have somebody you trust that you can go to in situations where you're uncertain. Pay attention to how you feel inside. Trust your intuition, trust your gut. If something feels uncomfortable, talk about it. Informed consent. Describe how you work with a client before starting to work with that client. To the best that you can, describe how you provide services, the services your agency provides, how you provide counseling, the kind of approach you take. Help people understand what they're getting into. It'll help you avoid crossing an inadvertent boundary. If you feel like you can't work effectively with a client for a whole variety of reasons, or you don't feel competent to work with a client, make a referral. Talk about it with your supervisor. encourage supervisees to talk about it with you if you're the supervisor. Don't go into situations where you feel uncertain about how to proceed. And when you plan to cross a boundary, for example, meet a client in the community, accompany them to the Public Assistance Office or the Child Protective Services Office, whatever it might be, make sure that they understand the limitations and use an informed consent process so that they know that this is an unusual event that's about to take place. And lastly, take careful notes of the rationale for crossing a boundary and for the results, what happened as a result. And if it was an inadvertent crossing and you're uncomfortable with the result, record it. Talk about it with a colleague, with a supervisor. Put the facts down on paper. It's amazing how our memories fail us over time. It's something that happens to me today that I think I'll never forget. A week later, I can't recall it. Here are some articles that Ken Pope suggests if you would like additional information about making decisions about crossing boundaries. These articles, I've reviewed these articles. They're very helpful. They have a lot of concrete ideas, things to think about that we just don't have time to talk about today. So I present them to you here. If you don't have time to jot these down, they'll be posted as part of the slideshow on the website. So here are some mistakes. I think it's important to talk about some typical errors that we make in crossing boundaries. I'm going to talk about 7 errors that we make. One is that what happens outside a session doesn't have much impact with what happens during a session. Even the most inadvertent encounter in the community, a client meets you on the street, you either choose to greet them or not based on confidentiality guidelines and the way your agency recommends you deal with those kinds of situations, or the counselor or the client might stop and introduce family members, and how you handle the introduction and how you handle the discussion. All of that can have a big impact on the relationship that the client has with the counselor. So to think that things are neutral or kind of inadvertent and not important, always worth a second thought. Crossing a boundary with a client is the same as doing the same thing with someone who's not a client. Again, context is everything. We have special relationships. Caregivers have special relationships with patients. Patients have all kinds of transference issues with their caregivers. So when we cross a boundary with someone who's a client, it's not the same as unexpectedly running across somebody or touching somebody who's a colleague or a friend or an acquaintance that we hadn't seen for a long time. Crossing boundaries with clients, potentially very impactful. Our understanding of a boundary matches the client's understanding of the boundary. Not always. My intent in coming to the funeral of a client, my intent in sending a condolence card, my intent in touching a client's shoulder is not always interpreted the same way. By the client. A helpful boundary crossing for one will be the same as for another. Again, you know, clients are individuals. They all respond differently. So what may be helpful to one person may not be helpful to another person. Offering to meet someone in a 12-step meeting may be very therapeutic and helpful for one person, and very threatening and alienating for another person. Thinking that boundary crossing is isolated and encapsulated and a one-time only event, probably a mistake. I'm reminded of a story about a counselor who is not going to be late for her appointment, but gets to the clinic later than usual, and stops to buy a cup of coffee and picks up a cup of coffee for the client because she didn't want to drink coffee with the client without the client having being served a similar cup. Inadvertently, she didn't realize that at the very next session, the counselor or the client's expectation is that, oh, maybe the counselor will bring coffee again, so I'm going to bring some pastries this time, and so that all of a sudden there's a complication in the relationship. Boundary crossings aren't static; they can have cumulative effects that we don't anticipate. Sometimes we have blinders on. And this last item has to do with blinders. If I don't see a conflict of interest, then there isn't any. And because I don't see a conflict of interest, it doesn't always mean that there isn't one there. I don't know how others interpret my behavior. I don't know how the client may respond. I don't know how other clients might respond. I don't know how other supervisees might respond. So be open to feedback. That would be the suggestion here. Be open to the feedback of others. Don't make the assumption that you're always right, and don't make the assumption that your interpretation of a given situation is correct. Be open to the possibility that something has happened outside your purview, outside your perspective. Your depth perception wasn't very good one day. Be open to the possibilities. And the final issue has to do with self-disclosure and making the assumption that self-disclosure is always therapeutic. I shared a few examples earlier of how self-disclosure might not be therapeutic. A humorous example is one which Ken Pope talks about on his website, in which at the conclusion of a series of counseling interviews, the client, unbeknownst to the counselor, was kind of keeping track of how much time the counselor spent doing self-disclosure about his own personal life. And at the conclusion of the series of interviews, the client discloses to the counselor that from the client's perspective, she's owed about $30 a session because the counselor was taking about half the time of each session with self-disclosure. So self-disclosure not always therapeutic. Just be open to the possibility that when we do self-disclosure, we may be meeting our own need rather than the needs of the client. All right. There's a second quiz that I'm going to ask Olivia and Tamara to introduce to you. Again, 3 questions.
And the first one, experienced counselors need supervision in the assessment and management of boundaries. True or false? All right, we're going to close the 99% said true.
Good, excellent. Yes, even the most experienced counselors will err. I remember one revered counselor in the very first agency I worked at. He'd been there for decades, was extremely effective with people with co-occurring disorders. And because of a lack of supervision or a failure on the part of the supervisor to notice some key cues, ended up having a sexual relationship with one of his clients, and of course was dismissed from the program. Second question.
Generally, our boundary issues arise more often than we think because we make assumptions about clients and counselors. True or false? We're going to get ready to close this poll. All right, 97% said true.
Excellent. Yeah, exactly. Let's go to question 3.
Guidelines about boundary crossings do not vary and should be adapted in all contexts or adopted in all contexts. True or false? %, said false, 7% said true.
Okay, a little bit more variation there, but the vast majority said false, and I agree with that. That we need to take the context of the situation into account before we make hard and fast judgments about whether a boundary crossing was salutary, whether it was neutral, or whether it was harmful. And boundary crossings, when harmful, are really boundary violations. It's something we need to guard against. But we need to take the context into account. Very good. Thank you, everybody, for responding to those questions. I have one more piece that I'm going to share with you, and then we're going to open it up for some questions before the bottom of the hour. I'm going to talk about what to do when a boundary crossing goes wrong. In the event that even a planned crossing didn't have the impact that it was expected to have, or it had a more negative impact than it was expected to have. My first suggestion is when we do make a decision to cross a boundary, that we monitor the reaction of the clients. We monitor the situation carefully. Be aware that a crossing is happening, and be aware of what the impact was. If in fact there's a complaint, or someone feels like they were injured, or takes exception, do take a lesson from our politicians. I tell you, our politicians remind us of this year after year after year. Take responsibility for what you did. Don't deny it. Don't make excuses. Take responsibility. Acknowledge the intent, perhaps, as well as the untoward impact, but do acknowledge your role in what happened. Thirdly, very important to be non-defensive. A classic defensive response is one that spends a lot of time explaining why I did something and ignores the impact of what happened. And that's a classic definition of being defensive. You know, you won't feel so bad if you just understand what my rationale was. The reality is, it doesn't matter what the rationale was. The reality is it didn't go well, or the client didn't respond the way we expected the client to respond. So being open to the fact that sometimes others interpret my behavior in a way that was different from the way I wanted them or intended them to interpret my behavior. Being open to that possibility. Fourth guideline would be when something happens that you didn't expect, collaborate with an experienced colleague. Get their feedback. Tell them what happened. If they were a witness, ask them for their feedback about their perceptions and their interpretation. Seek more than your own opinion. Seek the opinion of someone else that you trust. Listen carefully to the client. Try to understand. This will build your understanding, or build the counselor's understanding of the client, of the context, and what the client's needs are. Can be a untoward crossing of a boundary can turn out to have very salutary effects if it's debriefed in a way that's effective and the client feels taken care of, understood, and protected and safe. So really what you're doing there after you listen carefully is you're seeing the issue from the client's perspective. And finally, I got a couple more. Keep adequate, honest, accurate records. Each of those terms is different. Adequate means there's enough detail. Honest means that you're recording what happened from your perspective. Accurate means that you've got the key facts there in place: date, time, place, reaction, so on. Very important. And then lastly, if you made a mistake, consider making an apology. If it was an error on your part, acknowledge that it was an error, and acknowledge that you didn't intend for the consequence to come down the way it did. Sometimes apologies can be simply permission to do the same thing over again. When kids apologize and say, I'm sorry, it tends to resolve the moment, but it's not really an intention to change things in the future. I'm not talking about that. I'm really talking about, if you make a mistake, consider making amends and making a commitment to not doing it again. So, those are quickly some topics, issues around boundaries. We've covered a lot in the last almost hour and a half. We have about 5 or 6 or 7 minutes for some questions, and I encourage you to type in those questions into the chat box. And Tamara, I'm going to turn it over to you and ask you to screen those questions and share 1 or 2 or 3 with me, depending on how much time we have.
Sure. All right. The first question that we have is there a boundary issue when hiring a former client, say 5 years after treatment, into a counseling position at an agency in which they were treated?
Yes, there is a boundary issue, but it doesn't mean you shouldn't go ahead and make the hire. But be aware of, here are some issues that you need to be concerned about. What's written in that client's confidential record? If it's 5 years, the agency still has the record. So how can you protect the confidentiality of that record? Now, technically, the record is the client's record, and if the client or the former client chooses to seek permission, then that record should be reviewed by a supervisor, and a discussion should take place about whether or not it is in the best interest of the client to look at that record. So that's one issue. Another issue is we always have boundary issues around recovery. If the client is in recovery, how do we go about verifying the quality of their recovery? Too often we make hires without asking the right questions around recovery and self-care, and more, I have encountered agencies who are actually asking the applicant to provide a demonstration of their skills, to facilitate a group meeting, to do a brief interview, a recorded interview, to have it be reviewed by the selection panel, making sure that we're hiring someone who has the competence and the understanding of their role in order to be effective. Another boundary issue has to do with self-disclosure and what that particular individual's take on self-disclosure is. Too often in the past, the old-timers would rely on their own recovery and be very prescriptive about the way they recovered and prescribe those methods to clients. And today we're really trying to take a look at the fact that there are multiple pathways to recovery. So those are some of the boundary issues that I would be concerned about in hiring someone. Now, certainly if the person has been an intern in the agency or a volunteer and you've seen that person work, or you've had other contact, they've done a practicum in your agency, then some of those questions may be answered.
Okay. Another question. How do I work as a peer recovery specialist in regards to boundary issues and help them find a role between clinician and sponsor?
Oh, that's a great question. I think we're still wrestling with that issue as a field. You know, the peer recovery specialist, I'm going to make an assumption, and the person who asked that question can type in whether or not this assumption is correct. I'm going to make the assumption that the client is engaged with somebody else in the agency in the role of a therapist or a counselor or a facilitator, recovery facilitator, in addition to the peer recovery specialist. So in that case, it's really important for the peer recovery specialist and the counselor to share information, for the counselor to help the peer recovery specialist understand perhaps what some of the boundary limitations are with this particular client. What are the sensitivities? What are the learning needs that the client has? What are the treatment objectives? Why is the peer recovery specialist being asked to work with this particular individual? Really important for us to communicate those kinds of information to a peer recovery specialist before they start working with the client, so they're not going in kind of with a blindfold on. We want to help them have clear, vision going forward, so that they don't make inadvertent boundary mistakes. I guess another issue is, what is the job description? How clear are we as supervisors or administrators in developing job descriptions for peer recovery specialists? And I think boundaries and boundary issues need to be addressed in those job descriptions, and then people need to be trained to the job description and supervised to the job description, so that we know what, if there are clear limits. For example, if I have a peer recovery specialist who's male and is assigned to a woman in recovery, what kind of precautions do we provide so that the client's safety is preserved and boundary crossing, harmful boundary crossing, doesn't take place? I think we've got time for one more, Tamara.
Okay. If a counselor commits an ethical violation and the supervisor is unaware, is there a possibility that the supervisor is at fault as it relates to vicarious liability?
That's a good question also. The answer, I think, is should the supervisor have known, if the supervisor was doing a good job of supervision, would the supervisor have knowledge about the violation? If in fact, and then the other thing to look at, the courts or an attorney would look at, is what was the intent of the counselor? Was the counselor's intent when crossing the boundary, was the intent to keep it a secret? Because if it was the intent to keep it a secret, and the agency policy was clearly that any boundary crossing needs to be discussed with a supervisor, or policies about relationships with clients outside the agency, or encounters with a client outside the agency needed to be reported and discussed with supervisors, as long as that's part of the agency policy and procedures manual. If the counselor is acting outside of that, then the supervisor is probably not going to be held responsible. But if the agency has failed to be clear in the documentation of its policies and procedures, or the supervisor can be shown to be negligent in providing supervision. For example, if a client's family member complains about a counselor having engaged in a coffee appointment at a cafe with their daughter, for example, if that wasn't investigated and discussed and documented, and action wasn't taken, then the counselor and the agency are both on the hook for liability. So the question, a windy answer. The short answer to the question would be, should the supervisor have known, and did the supervisor perform supervisory duties that would have resulted in being informed? And was the counselor acting within the scope of the job description, or was the counselor acting outside the scope of the job description and keeping his or her behavior private? In either of those situations, the answer to those questions is going to impact whether or not the supervisor was liable. And I think that brings us to the bottom of the hour. I thank you all for participating. It was, I hope it was helpful. I'm going to turn the responsibility for the slides over to Tamara, who will have some final comments.
Thank you so much, Steve. Thank you, everybody, for your feedback. I know that we received a lot of questions. We're going to summarize those questions and have those available on our website. After this webinar, we would just ask that you complete a brief survey. You'll also receive your certificate within 10 business days. Again, these webinars have been recorded and will be posted onto our website. And we can send you that information as well. I know that Dr. Gallen had included some websites within the PowerPoint presentations, and again, those will be available on our website. Please join us Friday, July 6th for our next webinar, which will be Performance Success. Thank you so much.